Welcome to the conference session titled High-Risk MDS. Thank you for joining us. My name is Nyari. I'm the Patient and Professional Programs Coordinator at AMDSIF. As we get started, AMDSIF would like to recognize the generous support of our corporate sponsors. At the diamond level, we have Alexion and Novartis. At the gold level, we have Apellis and Genentech, as well as the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there'll be a question and answer session. When asking questions, please wait for the microphone so everyone can hear the question. And when asking questions, I ask that you do not share any private health information as the speaker cannot answer directly to your specific healthcare. Today's specialist is Keith Pratz. Dr. Pratz is a clinical investigator for novel therapeutics for acute leukemias and is an associate professor of medicine and director of leukemia program at the Abramson Cancer Center at the University of Pennsylvania in Philadelphia. With that said, it is my pleasure to welcome Dr. Pratz.
Great. Thank you for the kind introduction, and thank you all for joining us today. This is a nice forum. I hopefully will keep this content at a level where we can all learn from it. But please interrupt if you have any questions, just raise your hand. I'll be happy to slow down and go over any details that may be helpful for you all. I have a few disclosures. We do a lot of clinical research in these fields, and we'll talk a little bit about some newer drugs there on the bottom. So just as an overview, today we'll talk about what is high-risk MDS, what perhaps causes this. We talked a little bit with Dr. Matthews about some of the classifications and underlying etiologies of these cancers. We'll talk a little bit about the current treatments. We'll talk a little about how this disease, high-risk MDS, has really started to merge with what we call acute myeloid leukemia, historically been a distinct group of diseases. And then we'll also kind of round it out by talking a little bit about the novel therapies in development and the future of this field. So Dr. Matthews talked a bit about this, but in review for those who weren't here, the hematopoietic system, which is our blood-forming system, is where we all generate red blood cells, we generate white blood cells, we generate platelets. These have to live your whole life from infant fetal times to the end of your time. They are cells that have to grow and have to differentiate or mature into different types of cells. And there's different cohorts of them. There are really slow-growing long-term stem cells, and there are cells that divide every day or two to make your platelets. And some of that is reflected in the type of diseases that we see with those cells. What happens in cancer and in cancer of the bone marrow is there's a damage event somewhere along the development tree where there's a genetic change, and more often than not, it's more than one, where their cells downstream of that genetic change do not form normally. In this case, the cartoon's damaged cell is in the group of cells that generate platelets, and platelet counts drop, and eventually someone would realize they're bleeding and come in and get tested and find they may have something like myelodysplastic syndrome. If that problem develops more globally and overwhelms the ability of the body to make all blood cells, this generally is where we consider something acute leukemia, where no blood is being formed properly. It's a really medical emergency. A lot of treatments done in the hospital for this, and it can be life-threatening in a matter of days to weeks. So what I want to start by is setting kind of the precedent that myelodysplastic syndrome is a complicated disease. You heard a lot from Dr. Matthews about that, but it is a disease that we align with cancer. And partly because of what I showed on the last slide, it's a disease that's an uncontrolled growth or a lack of growth of certain types of cells in your bone marrow. It's clonal. What that means is it derives usually from one root, one genetic change, that lightning bolt came down on the one cell and changed it in a way that it permanently doesn't form proper cells downstream of it. In myelodysplastic syndrome, and that's kind of the focus of today's talk, this can be a more complicated genetic problem than some of the more aggressive cancers we call acute leukemia. And why that's important is the acute leukemias in some situations when there's not a lot of changes can be cured with chemotherapy alone. Whereas myelodysplastic syndrome and the types of diseases we would consider high-risk myelodysplastic syndrome are not curable with chemotherapy. The only current cure for most patients with myelodysplastic syndrome is something called a stem cell transplant. And for patients with high-risk disease, like we're going to talk about now, that's usually the goal of their care. It's heterogeneous, meaning there are some patients who can live many years, and we'll go over this later in some slides, with myelodysplastic syndrome, with minor changes in their blood counts and not a lot of needs for therapy. Sometimes this can be 15, 20, 30 years. And there's others that get worse very quickly and need treatment, and patients' lives can be shortened quite dramatically. It's not just the disease of elderly patients. We have patients who are young in their 30s with this condition. We have folks who are in their 70s and 80s. What's challenging sometimes is the distinguishing changes are not terribly different amongst the groups of people, the young and old, who get this. And we don't know why. We don't know why some young folks are hit with this. In many cases, we're learning a little bit more about the predisposition states of this condition in regards to family risks that you may carry from your parents and perhaps pass on to your children. These are important tests that we usually learn from our initial bone marrow testing. And there are many centers now like ours who will go to family members to see if there's a risk carried forward in certain situations. It's important, as Dr. Matthews mentioned earlier, to distinguish these conditions from other non-cancer related problems, which may affect the blood counts. And he went over some of these things in his talk, but low blood counts because of drug side effects, low blood counts because of autoimmune diseases, and vitamin deficiencies are rare causes that can mimic myelodysplastic syndrome, can actually look very similar to it under a microscope. And that's part of the reason why it's important to be seen when these conditions develop by a group of physicians and pathologists that see a lot of this. And then lastly, it's needs a bone marrow biopsy to make this diagnosis. Can't make these diagnoses on blood, partly because the blood doesn't always reflect what's going on in the bone marrow. And even when there's changes in the blood, there may be different changes in the bone marrow. So that's still the standard of the way in which we diagnose patients with this condition. And then the last bit of this that was briefly mentioned by Dr. Matthews is there are genetic changes that can be seen in normal aging, genetic changes that we all get risk for as we get older. Over age 65, about 10 to 15% of patients have genetic changes in their blood that look very similar to the changes we see with MDS, but are not the diagnostic of MDS. Don't always change to MDS. And part of what we've learned over the past few years is ways to distinguish people who have real MDS from people who have what we call CHIP, clonal hematopoiesis, and those topics are evolving year to year. How often is this found in the United States? It's about 20,000 cases of MDS per year. The median age is in the late 60s. The risk factors that were mentioned earlier, there's some ones that aren't terribly surprising, like exposures to radiation, chemotherapy, occupational exposures, particularly people who work in the petrochemical industry, exposures to benzene derivatives. In this general area, one of the other big risks is radon exposure in the home. So making sure your homes are tested, mitigated for radon is an important thing we should all do when we buy a house, because it does put you at risk for MDS along with lung cancer. There's a number of genes here on the bottom of this page. Won't go through them all, just say that they're rare. causes for familial MDS, and we pick these up by the sequencing testing that we do on their bone marrows. So all the things were mentioned earlier, I think, by Dr. Matthews. These are more for clinicians to say that there's a lot of different things that need to be done to be sure that we know we have MDS and not some other treatable problem like a vitamin B12 deficiency. There's a lot of things that we learn with that initial testing about the prognosis of the blood changes that may be there. And there are other therapeutic things that we learn in rare situations, very simple to treat conditions that can look like myelodysplastic syndrome. For instance, a condition called chronic myeloid leukemia, where there's a single pill you take once a day and essentially cures that condition. So those are part of the reasons why the testing for the genetic causes of these conditions can be really important. And in the next 10 years, I expect these treatable conditions associated with MDS will evolve to accomplish treatments for more patients. When do we treat patients? Well, these largely are dependent on the degree of low blood counts in patients. The high-risk patients, and I'll talk a little bit about what we define as high risk in a moment. We sometimes will treat earlier in their disease process, meaning before they need blood transfusions, because we're trying to prevent this problem called acute myeloid leukemia. And there was a question in the previous session about the role of drugs to prevent or lessen the likelihood of transition to acute leukemia. And that is one of the reasons we treat patients. We do sometimes treat directly at the time of diagnosis young people with MDS, meaning that if we find genetic markers for MDS and we find minor changes in their blood counts, we will make a decision early on that we want to try to cure that patient with a stem cell transplant, and we will directly take them either to a transplant or chemotherapy before we might do it in an older adult. And then the general rule of thumb in defining what is high-risk MDS is the number of very immature blood cells in the bone marrow, they call blasts. And when the number is above 10%, by most classification criteria, we would put those in the high-risk category. Dr. Matthews showed a slide similar to this. I'm going to just try to simplify this a little bit for the folks that don't do a lot of this. We look at the genetics of the patient. We look at the blast numbers of the patient. We look at the hemoglobin or the red blood cell count of the patient. We look at the platelet count of the patient and the neutrophil count of the patient. And we score those and give them points. And then those points get added up to determine one of these risks here. And for the non-clinicians in the room, step away from the microphone. These curves mean the likelihood of being alive after time on the curve. So this blue curve, for instance, half of the patients in the very high risk category have died by 1 year of their disease. And that's what that curve means. Versus the green curve, which means very low risk patients, 50% of the patients will be alive close to 10 years. So that's the difference between what we call very high risk disease and very low risk disease. And a lot of therapy decisions are based on what risk the patient has when we make the diagnosis. One of the challenges beyond what we mentioned earlier about the genetics, the cytogenetics, is that there are dozens of specific gene changes that are associated with the development of MDS or acute leukemia. The relative frequency of which is described here. Some of the changes, such as TET2 and AXXL1, are genetically altered in 20 to 30% of patients with MDS. Whereas others, including some of which have specific pills to take for them, such as IDH1 or FLT3, are mutated in less than 5% of patients. So finding those needles in the haystack becomes important for when we make a therapy decision, because some of the treatments are really only effective for the patients with the specific genetic changes. And that's part of what we're refining and hopefully getting more tools for in the world of MDS and acute leukemia. And as was mentioned by Dr. Matthews earlier, 90% of patients with MDS have a genetic change as found by these current panels. And that becomes important because if we don't see a genetic change by these panels, we really have to go back to making sure we're not missing some other cause of their low blood counts that's not MDS related. And that's what a lot of the specialists in this field spend a lot of time working on. This is a very busy slide, not to delve too much into the details, except to say, because of that heterogeneity, because of that diversity in how patients survive with these conditions, there's been a lot of effort made to distinguish the people who are going to live without treatments for 10 years or more from those patients who may need treatments very quickly and otherwise would get sick very quickly. And this most recent iteration of their changes in 2022 is the current strategy that we use to make therapy decisions. And interestingly enough, the high-risk MDS patient population that I mentioned earlier, those patients with more than 10% blasts, have now been combined with what we call acute myeloid leukemia. And why is that important? Well, it's important because the therapies that have evolved most quickly over the last 5 to 10 years have been in the myeloid leukemia space. Drugs have been approved there, whereas they haven't been approved for the high-risk MDS patient populations as of yet. But the current international groups here are lumping these patients together with hopes of getting more access to the newer drugs for patients with high-risk MDS because the outcomes are very similar. And I will just say there are now 10 to 20% blast patients that are in the same cohorts of patients with acute leukemia, the specifics of which don't matter much here, except to say, if you are in that high-risk group, the therapies that we give for acute leukemia overlap a lot with the high-risk MDS patients. And this is just to show you that the life expectancy, and this is a curve just like we showed earlier, for patients with acute leukemia in blue versus patients with high-risk MDS in red overlap a lot. In fact, they overlap to the point where the patients with MDS have high-risk MDS have a somewhat worse outcome than patients with acute leukemia with the treatments that were given 5-10 years ago. And this may change more recently with some of the newer treatments, but this is part of the reason why we're grouping the high-risk patients, high-risk MDS patients with acute leukemia now. And I think that's just a message that's starting to evolve in the clinics and doctors' offices and research papers. I mentioned earlier the heterogeneity of this. This is just another new way of breaking it down in 2022. There are 7 or 8 or 10 subgroups here, some of which go from 100 median overall survival of 110 months to as little as 13 months. And that's part of the challenge with describing to patients how your MDS might be different or better or worse than the normal group at large. Dr. Matthews showed this slide, which just shows a lot about how we treat patients with low risk or very low risk MDS from observation to specific subsets of patients with MDS, such as deletion 5q with drugs like lenalidomide, to patients with anemia with drugs that stimulate the red blood cell production, like erythropoietin stimulating agents, or a drug called luspatercept now, to other new therapies that I'll show a little bit later. But most of the current treatments for the high-risk patients involve drugs called hypomethylating agents, and specifically two drugs. One's called azacitidine, the other one's called decitabine. Patients, if they are transplant eligible, will get one of those two drugs and then ideally pursue a stem cell transplant. Stem cell transplant session will be later today. Most centers who do a high volume of stem cell transplants will offer transplants to patients up to age 75 fairly routinely. There are experimental protocols beyond that at many centers, but medically it gets to be difficult as folks get older to do these really aggressive transplant-related topics. The question earlier about the standard treatment came up, and one of which has not changed much in many years. This is now a 20-year-old drug approved on this study. It's azacitidine. Azacitidine is a drug that you take 7 days per month. It's most commonly given as a under the skin injection, but can be given intravenously. And this was the study that led to its approval, which was comparing azacitidine to supportive care or transfusions or standard chemotherapy for acute leukemia or low-dose chemotherapy. And this was high-risk MDS patients, up to 30% blasts. And the outcome of this study showed that azacitidine treatment on average led to a survival of 24 months versus 15 months for patients who got one of the other supportive care or high dose or low dose cytarabine based treatment. So that's been our standard of care for the past 20 years. There have been a lot of ways we've tried to improve on this, and I'll talk a little bit about that in a few slides. Dozens of drugs have been added to azacitidine without a lot of benefit beyond what was seen here. There's another drug on the market that was approved more recently called decitabine. Decitabine or azacitidine are essentially used comparably. Decitabine is given 5 days per month. It's given intravenously currently. There is an oral formulation of decitabine that's been approved in the last 2 years. But we think of these drugs interchangeably because this study in high-risk MDS showed a survival of 11 months for azacitidine or 12 months for decitabine. Statistically, that's no different, and that's part of the reason why some patients get azacitidine and some patients get decitabine. The other thing that it comes up often is, should patients get 7 days of treatment per month or 5 days of treatment per month? This study compared 7 days versus 5 days. Numerically, the 2-year survival of the 7-day group was 35% versus 22% in the 5-day grouping. So currently our standard of care in the United States is to give 7 days of azacitidine for this treatment. I mentioned earlier, an oral formulation of these drugs have become available. There's a drug called oral cedurazidine, decitabine. It was approved a couple years ago now, based on comparable exposures in the blood of the drug. And I won't go into so much detail except to say it's an alternative option for homebound patients or patients who can't easily get in to see their clinicians for several days in a row. And in my experience, it's a little bit more likely to suppress blood counts than the IV formulation, but it is something a lot of us use fairly routinely. And then Dr. Matthews briefly mentioned this, but there is a form of MDS that's related to an overactive immune system, and it's called hypocellular MDS. It's somewhat rare. It's more common in women, particularly those under age 50. And it's treated with a cocktail of drugs to suppress the immune system. Won't talk too much about this except to say this is part of the continuum of treatment options. Some of these patients do have some durable responses with drugs to suppress the immune system, but I would say it's not a very common issue. And this is an aplastic anemia foundation talk to say that this subset of MDS does overlap with the exact same treatments that we give to the aplastic anemia patients, with some of the durability of those responses being similar. So novel therapies for MDS and acute leukemia have come and gone. The one that was most interesting up until last year was a drug where we encouraged the immune system to see some of this MDS cells in the bone marrow as bad. We blocked one of the we call checkpoints for the immune system, something called CD47. And there were two drugs that came off development because they failed clinical research development by not approving the outcomes over azacitidine alone. A lot of patients treated on these trials, more than 2,000 patients total. So unfortunately, that didn't lead to any development. There are a number of other immune-based targeted agents that I won't go over today, except to say that none of them have gotten to the point of approval. There's a drug that I'm going to talk a little bit about in the next few slides called venetoclax. This is a trial that's completely enrolled now. It's for high-risk MDS. It's approved for acute myeloid leukemia in 2018, and it's really revolutionized the way we've treated acute leukemia for older adults recently. Imetelstat was mentioned earlier by Dr. Matthews. This is a telomerase inhibitor. It's really only approved for low-risk MDS. So there's some studies going on in high-risk disease now. Then there's a couple drugs that have been approved, one drug that was approved, ivosidenib, and a second drug that was approved for acute leukemia, but not quite MDS yet, called enasidenib, that are IDH inhibitors. These IDH genes are mutated in about 15% of patients with MDS or acute leukemia. The drugs themselves are very specific inhibitors of these bad cells, and have, when we find the rare case of this, have been used, and now ivosidenib is approved for MDS patients. And then there is a number of clinical trials at almost every local comprehensive cancer center for MDS. They change month to month, and it doesn't do us a lot of good to go over the ones that are available today because it'll change in a week. But the MDS Foundation, Leukemia Lymphoma Society, and clinicaltrials.gov are great resources for patients and families looking for clinical research in this field, and directly connecting you or your family with a clinical trial in the local community can be accomplished through navigators for those groups. So venetoclax is the one drug I wanted to cover a little bit. Venetoclax is a pill you take by mouth that targets something called BCL2. BCL2 is one of the components of cancer cells that prevent them from dying normally. And this drug allows cells to die normally and is given with azacitidine. The efficacy of this was shown this past year by Dr. Garcia from Dana-Farber at our American Society Hematology meeting. This was a study where they just gave the same dose we give for acute leukemia of venetoclax with azacitidine, and they gave it for 14 days per month. They treated patients who are on average 68 years old with a number of different blast percentages, and they had a response rate of 80%, which is good. For this disease, historically, the response rates have been on the order of 40 to 50% with most azacitidine-based treatments. It takes a few months for these drugs to work. The median time to response was 2.8 months, and the median duration of the response was 16.6 months. So not a cure for most patients. It was found that they had transition to acute leukemia in 12% of the patients on the trial, and it took about 6 months for that to happen. This just is a slide showing the duration of response, as I mentioned earlier. and then the overall survival of the patients treated with this. High-risk MDS patients, median survival was somewhere around 26 months in this study. So not a cure for everyone. There's a lot of folks here that are eventually dying of their MDS, but in the current time, we've been using this treatment as a way to get their condition under control better, the MDS under control better, so that we could do something called a stem cell transplant in effort to cure patients. Won't go into this too much. Another interesting part of this trial was about 46% of patients became transfusion independent. Red blood cells was higher number, 61%. Platelets improved in 72%, but both improved about 57% of the time. And then there are a number of side effects with this combination. It is a bit more aggressive than azacitidine alone. The major side effect with any treatment for MDS or acute leukemia is infections, and that was seen in about 60% of patients on these treatments. The reason I tell you this is treatment that does require a lot of monitoring and a lot of medicines to prevent complications. But the hope would be that we've got better drugs to prevent infections now than we did in the past. And as such, some of these complications, why they are numerically high, can be managed most of the time outside the hospital. And then I mentioned earlier, the goal of these treatments in many cases are to pursue something called a stem cell transplant. This was also some data that was presented by the MD Anderson group at ASH this year, our American Society of Hematology meeting, where they took patients after venetoclax and azacitidine to stem cell transplants. 86% of the patients who went to transplant had a response to this treatment. And the duration of response after transplant, or the likelihood of staying in remission after transplant, is summarized in this slide. Say that at 2 years after transplant, 71% of the patients were still in remission, which is a very high number for patients with this disease. It's been the case in the past. This number would more typically be in the 40% range. So we think this is an improved outcome, but the drug combination, venetoclax and azacitidine, still has not been approved by the FDA for high-risk MDS patients. There's a couple other interesting treatment options that are out there right now. This is a treatment that we give for patients with acute leukemia. It's a drug called CPX-351. This was a study that was designed for patients who had acute leukemia, acute myeloid leukemia, after MDS. And this drug, CPX, outperformed our standard treatment called 7+3, led to approvals there. And we're starting to use this drug in patients with high-risk MDS in certain circumstances, as opposed to using azacitidine alone. So more to come on this. They're currently studying it in MDS patients. So in conclusion, MDS therapies are evolving very quickly. There are a number of drugs in development. There's some really promising drugs, which I do think are going to get approved soon. A lot of effort in making these treatments more practical for patients. The older treatments involved a lot of care at the clinics. The hope would be that a lot of newer therapies are either oral or drugs that can be given at home infrequently. And the hope would be that allows larger patient populations to benefit from our newer treatments. We really need more enrollments in clinical trials. So this is part of the way we learn how to improve therapies. So I'd encourage anybody that's approached for a clinical trial in their local practices to really consider that as a way to either get newer therapies sooner or help us understand the current therapies better, so that in the future we can improve the outcome of our patients. quality of life is an important topic. Quality of life for patients with these treatments is very complicated. There's a lot of care, there's a lot of weekly visits, there's a lot of lab tests, there's a lot of family support necessary to do these treatments. Some of the things we're doing more recently are improving the quality of care, but I think, or quality of life rather, but I think this is an important topic to talk about with your clinicians or with your doctors when you see them about what's my life going to be like, not just next week, but 2 months from now and 6 months from now, because those are considerations you have to think about when you embark upon this. Do I have the support necessary to do this? Am I going to benefit from this? These are important things to think about, not just whether I'm going to get sick tomorrow. I think there's two components to this. Costs are a big issue. The new drugs are very expensive. Access to expensive drugs is a problem almost in every medical field right now. One thing I would say about that is many times patients have copays that are challenging to meet. There's a lot of copay assistance programs. Work with your doctor's offices, work with your pharmacy support. There's a lot of grants and other ways to get access to newer drugs. Costs shouldn't be a limitation, but in reality, they often delay treatments for many patients. So I'm going to stop there, open to answer any questions. I'm hopeful that we can see improvements in this field, and we're doing a lot of work as a group with communities like yours to answer on kind of what we're doing in real world. So thank you. Questions?
Thank you, Dr. Pratz. Do we have any questions?
Doctor, you mentioned with the approval of the oral medication at home, but you were keeping it for the more homebound patient. Does that mean it's more effective to go into the clinic and get the infused treatment?
Yeah, it's a good question. It's a good question. I guess I didn't mean to say that I in that particular way, but I did say it that way. I'm using it in patients at home all the time who are ambulatory, who are living a normal life, getting back and forth. I will say though that in the past, some patients just couldn't get in for the amount of days that we needed to do this because they couldn't drive or they didn't have family. So this gave some access to some of these treatments for those patients. But the oral forms work just as well, seem to work just as well. They do have some side effects that we still need to check your blood for and make sure you're tolerating well. So that part hasn't changed. But I think it does bring up the question was whether it makes your quality of life better because you don't have to go to the doctor's office 5 days in a row and that 7 days in a row. That's a real benefit.
Thank you.
Hi, Doctor. Thank you for your time today.
My pleasure.
My question is, are TPO-RAs more appropriate for lower risk, or can it be applied to higher risk with respect to, the thrombocytopenia?
Yeah, it's a good question. So the question is about the drugs that stimulate the platelets to be produced. And the drugs that are on the market are technically approved for something called immune-based thrombocytopenia, or ITP. We're not using them for the high-risk MDS patients. There's a couple reasons why, but the main one being some of the early development suggested some growth of the blast cells in the bone marrow. And there's also very limited data that it works in these higher grade patients. So we're not currently doing that. But there's efforts being made to try to figure out a way to make platelets kind of grow more readily. Turns out the biggest key to that is getting rid of the bad cells in the bone marrow. The chemotherapy is really the goal of that. That last treatment I talked about the venetoclax and azacitidine-based treatments, can clear the bad cells out of the bone marrow quickly enough that within 20 days of starting the treatment, the platelets come back up to essentially normal ranges. And you don't need those drugs like was mentioned there. But that's not everybody. That's a cohort that's really doing well with the treatment. But the TPO drugs we're not using for the high-grade MDS patients.
More questions?
Hi, in the last two, maybe not the last two slides, but you mentioned with the venetoclax and the AZA and the CPX 351, both those clinical trials were done in treatment naive patients.
Yeah.
Can you expound on that? As opposed to patients that have had, I don't know, a stem cell transplant or something else.
Yeah, it's a good question. So most trials leading to the approval of a drug are done in patients who had not had a lot of prior therapies. Both of those trials that I've showed you there are patients who had not had prior treatments. The question is, would it still work in somebody who had had previous treatment? And the answer usually is yes. I could say that because most of the ways we've looked at these conditions in the past would be that people who have had a remission that lasts for more than 6 months essentially regress back to new patients in regards to how likely they are to respond to treatments. But for a lot of reasons, drug companies and the FDA like a clean data set to work with, and not dealing with, competing prior treatments and other things. So we are using both of these treatments in people who've had their disease come back after previous treatments. And for the most part, it works reasonably well. But you highlight an issue, which is despite transplant and despite, that being the goal for a lot of people, it doesn't cure everyone. And we still see relapses, and we still see needs for more treatments or improved treatments at that point. And I do think we're making progress with that.
And let's say I was thinking that the idea would be get it approved for, treatment naive patients and then follow it up with patients that have had other sorts of treatment, but at least get it approved for something first.
Yeah. And interestingly enough, the United States, and this doesn't apply to the whole world, but the United States has much more ability to repurpose or use drugs off label than many centers in Europe or Central South America, where there's a lot more regulatory constraint about using a drug for a specific group of patients. So sometimes subsequent studies are done in the relapse setting and second line. But the gold standard is get the drug approved for the largest group of patients. And in the front line, that's what most of the trials are aimed at. So. Any questions online by chance?
Do you have a question on combination therapies? It's a two-part question. The first one says, are there any new combination therapies that are showing promise in treating high-risk MDS? And then the follow-up is, what are the advantages and potential side effects of combination therapies?
The first question is, are there promising combinations for MDS? And there are a number of them. There are drugs that are pills that are being added to it. There's a number of specific targets. I will say that the ones that are were the farthest in development, both fell off, failing to meet their primary endpoints this year, which is a disappointment because we all want more therapy. more options as far as therapy is concerned. The common theme, and one of the reasons why one of the drugs fell off, though, was to answer the second question, which is even when we saw a little bit of an improvement in the clinical response rate, that was eliminated or erased by complications and infections being the main one. And I won't, call out the specific drug except to say that there is a cost for most of these treatments by adding more treatment to them. And that comes in the way of complications and infections historically. So that's one of the signals we look at very closely for these new treatments is even if it works a little bit better, at the end of the day, is it's as safe or safe enough to get approved. And then at least for one of those drugs that failed to be approved, it was a safety issue that wasn't outweighed by any improvement in their response rates.
I do have another question. And this is on advocacy for patients and their caregivers. It says, how can patients and caregivers best advocate for themselves to stay informed about the latest developments for high-risk MDS?
This is one of the forms by which patients and families can kind of stay up to date is getting involved with an advocacy group such as this. There are a number of others beyond this one. Leukemia Lymphoma Society, for instance, has some patient forums and resources that are options. There are local options that many cancer centers, as far as support groups are concerned, often organized around the social work teams in those hospitals. So that's an option. But having dialogue with your clinicians, your doctors, along the way, not waiting to the point where you actually have to make a decision about a change. A lot of my visits are, you're doing well, we're not going to change anything. But the next question from patients and families can be, in the event that my condition gets worse, what do you think perhaps are going to be my options? And that's a good use of your time to think about, are there many options? Are there not many options? Are there going to be here, or am I going to have to go somewhere else to get them? Because that's forward looking is important. They're hard conversations to have. Unfortunately, almost everybody with these treatments has their condition get worse at some point and needs to make a change. So that's the place where I think you can get the most specific information about your family or yourself.
Thank you. I think you had touched on this one a little earlier, but maybe you can reiterate what you had said. But this one says, what factors are most critical in determining prognosis for high-risk MDS patients?
Yeah, this slide probably summarizes the best, which is there are a number of genetic changes and changes in the number of immature bad cells in bone marrow samples for cases with MDS. Your doctor will plug in and give you the exact subgroup you fall into here. And then, as Dr. Matthews said, there's a IPSS scoring system that's based on some older data, but sometimes is just as important. That gives you some semblance of an idea of what to expect from your disease. The challenge with this is outcomes on a large group of people. And really what's on this slide is the average outcome of that group. And as you all remember, averages are just, some people do better than average and some people do worse than average. And actually, that's the other challenge to this disease, which is there's a lot of variability even in the groups of people that we take care of. And you can see here, even in the very high risk group of patients, there's 10% of people who live 10 years. Picking out that group is not always easy for your clinicians. But that's the lesson here, which is the genetics most of the time drive your markers of genetic changes are complicated. And it varies from people living 10 years to people living a little bit more than a year with these conditions.
Mm.
Yes, Doctor, another question. You had mentioned earlier for people looking for clinical trials, there was a website and I didn't get to jot that down.
Yeah, it's clinicaltrials.gov is the best up-to-date resource for this. You can just Google clinicaltrials.gov and it'll come up. We're actually mandated to keep that up to date within 48 hours of trials opening and closing. Some of the other advocacy groups do this also, like this one. But I find the clinicaltrials.gov is probably the best resource. That resource allows you to put in your disease, MDS or leukemia or whatever, allows you to put in your location where you're looking for the treatments. And sometimes if you're interested in a specific target or a specific drug, you can put that in and find a place that's doing that research. In that website, we'll also give you contact information for the hospital or doctor that may be running a clinical trial. And that's an important resource to have out there. And it's updated routinely. It'll tell you whether they're accruing or not, whether they're active or not on specific trials.
Okay, thank you.
This is not an online question, but I've seen a lot of talk recently about personalized care in bone marrow failure care. And I don't know if you can speak a little bit about how this personalized care is being applied to high-risk MDS patients, and if there are any like specific case studies that show that this is a better approach to what was being done prior.
Yeah, I think the theme of my talk has been there's a lot of variability in how patients do with this condition. I think some of it is because the cause of the cancer problem itself is very different from person to person. But buried in the haystack of all these cases are subsets of diseases that you can apply a personalized approach to manage. And I mentioned two of them earlier, which are drugs that target something called IDH. This is IDH mutant leukemia or MDS here, IDH1 and IDH2. There are pills by now that you take once a day that have very little side effects and work remarkably well to manage that small percentage of patients. And I would consider that a personalized approach because that's really your cancer has got a key to managing it. And I think that's helpful for the small group of people that it applies to. But the other piece that's a little bit interesting on this is while some of these changes don't have specific keys like that, we know some of the changes have drugs that work better in certain situations. So Dr. Matthews talked a lot about a drug called lenalidomide earlier. This is very effective in patients with a 5th chromosome change, right there, del5q. You can see that's about 15% of patients. And that's another example of personalized care. So we use the genetics to really personalize in some sense when it's applicable. But there's a laundry list of patients that don't have a personalized approach, and we're still doing a lot of kind of uniform care. And the clinicians that help manage your case hopefully will think about what personalized options are out there and apply them if they're appropriate.
Questions in the room? Thank you so much, Dr. Pratz,
Thank
for
you.
sharing your time and expertise with us today.